So I was given a case of 4-year-old male child with complaints of inward deviation of right eye since 8 months of age, requiring cosmetic correction, and with a history of double vision. No other positive history. There was no history of abnormal posturing or no history suggestive of serious and CNS anomalies, ocular trauma, birth history was normal, no history of musculoskeletal disorders, um, no history of delayed developmental milestones, and influenza, measles, meningitis, and encephalitis, no history of cyanotic stress. In the family history, no history of similar complaints in the family, and no history of malignant hyperthermia in the family. Local examination, there was no abnormal head tilt. The right eye was medially deviated, and the visual acuity was 6/6. And left eye, there was normal gaze, and right eye, there was esotropia. So it's a case of isolated monoocular squints, right on the right eye.
That's right. Divergent or convergent squint?
Convergent squints.
So if the eyeball is towards the midline or the nose, then it is a convergent squint. If the eyeball is rotated to the lateral aspect of the eye, it is a divergent. Okay. So you must ask the patient to look straight and see which side the eyeball is rotated, whether medially or laterally, and say whether it's a convergent squint or a divergent squint. Okay, right. Now, what are the challenges in this patient?
So this is a pediatric patient.
Very good. Pediatric
requiring general anesthesia. There is risk of ocular cardiac reflex in the intraoperative period, oculoemetic reflex, oculorespiratory reflex.
You say it's a pediatric patient. Specifically, anything else in this group, age group?
Sir,
4 years old.
4 years old male child.
Yeah. Anything else you have to add? The pediatric age group, but 4 years. Any specific reason for the age?
Separation anxiety.
Separation anxiety. The patient will not be cooperative. Yes, so you have to find out a way of carefully separating it from the mother or the attendant. Okay, so that should always be added. Only children or infants less than 5 months, you can say there will be no separation anxiety. Any child above 6 months of age, you must always mention there will be the problem of separation anxiety. You should not forget that. Okay.
Ocular cardiac, oculoemetic, and ocular respiratory reflex. Force reduction test, and risk of malignant hyperthermia, and it can be done as a daycare procedure.
Okay. So if supposing the family history of malignant hyperthermia is positive, how are you going to proceed?
I will avoid the halothane and the nitrous swollen, and I will do it under total intravenous anesthesia.
Avoid scoling. What else you have to avoid?
Halothane inhalation agent.
Any inhalation. Earlier it was halothane. Nowadays halothane is not being used. So better to avoid the other inhalation agents also, like thiofluorine, isofluorine, and go for total intravenous anesthesia in the form of propofol and midazolam or ketamine infusion and maintain. Can local anesthetic injection be given for a block if a patient has got a positive history of malignant hyperthermia in the family?
Yes, sir, we can do. We can use it.
You can give. It is better to avoid local also. Okay.
Yes,
so how do you confirm that whether the child is there is a possibility of malignant hyperthermia in the patient or not? What are all the pre-op investigations you can do?
So, caffeine contraction testing. Genetic testing.
So the caffeine test is very important. That can be done. And what is the mechanism of malignant hyperthermia?
Mutation in the ryanodine receptors.
What is the role of ryanodine receptors?
That will cause sustained muscular contraction.
Why?
Calcium, because of sustained calcium release.
Calcium release from where?
From the sarcoplasmic reticulum.
Endoplasmic reticulum. Okay. So
Endoplasmic.
calcium first enters the muscle cytoplasm through the T tubules, and then this entry of calcium releases the calcium from the endoplasmic reticulum by the opening of the ryanodine receptor. Okay, in a normally functioning ryanodine receptor, after the calcium gets attached to the troponin C and initiates a muscle contraction by causing the actin myosin complex to shorten, it will be removed, and then it will be reuptake will be happening within the sarcoplasmic reticulum, and the ryanodine receptor will close that leaking. Whereas in a malignant hyperthermia patient, this ryanodine receptor does not allow the re-entry of calcium into the sarcoplasmic reticulum. So there is a sustained release of calcium from the ER, which goes on stimulating and producing a tight contraction. And that contraction causes the increase in the metabolism, increases the rate, and patient's temperature goes up. That is how the whole process of malignant hyperthermia happens. So how do you treat that condition?
So we have to stop any stimulant like inhalation agent or pollen, and we have to notify the person, call for help, administer intravenous dantrolene 2.5 mg per kg as initial bolus, and can repeat up to 5 to 10 milligram, 10 milligram, and support airway breathing and circulation. We have to maintain.
Support. So dantrolene sodium is the definitive treatment. Okay. So how does dantrolene sodium work in this condition? It causes the uncoupling of the calcium with the troponin C. Okay, that is how it causes the relaxation. It is something like a muscle relaxant only. So the main action is by uncoupling the calcium from the troponin C and reducing the stimulation of actin myosin complex and relaxing the muscle, thereby reducing the heat production as well as relaxation of the muscle. Okay, so that is what we have to remember for dantrolene. So all these questions can come when you say malignant hyperthermia, because if the examiners go on asking about oculocardiac reflex and oculohemetic reflex to other people, suddenly they may ask you about this particular problem also. So what is the pathway for oculocardiac reflex? What is the afferent, what is the center, and what is the efferent?
Sir, afferent extraocular muscle stimulation, we pass to the long and short ciliary nerve to the ciliary ganglion, and from there to the via the trigeminal nerve to the Gazerian ganglion, and it relies on the brainstem nucleus, central nucleus of trigeminal nucleus in the brainstem. From there, it stimulates the motor branches of the motor nucleus of the vagus, and the vagus will. These are cardio depressor nerves, so they will depress the sinus nerve, sinoatrial nerve, and cause
bradycardia is the common presentation, isn't it? When the oculocardiac reflex occurs, bradycardia will be the clinical presentation. So how do you treat that?
Sir, we have to decrease the stimulation. Ask the
surgeon to stop. Very good.
Stop. Increase the depth of anesthesia. Correct hypoxia, hypercarbia, and atropine 0.01 mg per kg you can give, or glycopyrrolate.
So initially you don't immediately use atropine. You wait for some time after the stimulation is aborted by asking the surgeon to stop. Usually after 2 or 3 attempts, it will stop and get corrected by itself. Very rarely, when the heart rate goes below 40 in a child, then and does not respond to stopping the surgery, then you have to give atropine. Okay? Otherwise, you can wait and then it will automatically get corrected. What is the most important post-operative complication after a squint surgery?
So, post-operative nausea, vomiting.
nausea, vomiting. Why this? What is this? You said about oculoemetic reflex. What is the pathway for that?
So the extraocular muscle stimulation will stimulate the vestibular nuclei via the medial longitudinal fasciculus, and it will stimulate the vomiting center, which is in close proximity, and vomiting can
Vomiting
occur.
will happen. So what
This
are
should
the
be
methods
avoided by
of
giving.
treating it, preventing and treating this post-op nausea and vomiting in squint surgery patients?
So we can opt for regional anesthesia, dexamethasone 0.01 mg per kg, ondansetron 0.01 0.1 mg per kg, dexamethasone 0.1 mg per kg. Or we can give propofol.
Propofol is only for a short-term use, not for this particular condition. So these two drugs, what is the latest antiemetic that is being used? Which was introduced for onco patients, now used in anesthesia.
Repeat, sir.
Eh?
Neuropenin antagonist. Neuropenin
Neuropenin
antagonist.
1, apretin. Okay, so that is the newer drug that is regularly now being used compared to ondansetron also was initially introduced only in onco anesthesia. But now the neuropenin 1A receptor antagonist is the more prevalent drug which is recommended for more effective anti post-op nausea and vomiting treatment. Okay. So these are the common questions that will be asked in the examination. Usually it will be invariably a pediatric patient. So above 6 months, you remember to say about separation anxiety, and suddenly they may ask you about the airway changes compared to the adult, or the cardiovascular system changes, comparison of all that between an infant, child and an adult. So you must be prepared to answer all those questions. Then, particularly with regard to strabismus or squint surgery, the common intraoperative problems like oculocardiac reflex and post-op problem like oculoemetic reflex. This oculo-respiratory reflex is not under anesthesia if you are going to do any controlled ventilation. The patient will not be breathing. In a spontaneous breathing patient, then you may have this reflex also. And the technique of choice for children is always general anesthesia. So you go for an induction with IV propofol, and because of the associated syndromes like muscular dystrophies or other malignant hyperthermia, it is always preferable to avoid scoline in these patients and go for a non-depolarizing muscle relaxant. Secure the airway with a oral ray tube so that it doesn't interfere with the surgeon's field or project when they drape the patient's face. So preferred tube will be a oral ray tube with a cuff, or a flexometallic LMA also being used with people who have experience with LMA, and make sure that you connect the breathing circuit correctly and fix the tube properly, because intraoperatively getting access to the airway will be very difficult because they will completely drape the face. And for analgesia, you can use non-opioid techniques, because these patients are more prone for post-op nausea and vomiting. Opioid-free analgesia in the form of paracetamol, IV lignocaine, or magnesium. All these things are being tried nowadays, so that will be a better method of analgesia rather than going in for opioids. Okay? So these are the common things that we have to know. Right. Okay. Who is presenting the next one?
So I am presenting.